Okay, welcome to this podcast for Chapter 16 involving private health insurance. Team 8 has been assigned to make a videotape case presentation involving the case at the beginning of Chapter 16, involving Barb et al., who is a recent pharmacy school graduate. She's looking at a group policy to buy. It has an elimination period, and she's wondering about when, if she should take this insurance when she takes a job in a pharmacy chain. So again, Team 8 has been assigned to make that presentation, so I won't get too much into that case at all. There are 21 pages of text from the textbook involving Chapter 16. I want you to take a look at 5 different diagrams in this chapter. First of all, there is figure 16.1 involving the iron triangle. We have the iron triangle as part of this presentation later, but I still want you to take a look at figure 16.1. There is table 16.1 involving people without health insurance, coverage by characteristics. These are vulnerable populations. Also figure 16.2 involving national health expenditures. Figure 16.3, the third-party prescription industry. And finally, I also want you to take a look at table 16.2 involving the changes in pharmacy operations from 1986 to 2013. Again, there's 21 pages of textbook. There's 32 slides in this particular podcast. We will have 5 IRATs to cover as part of this podcast. There are 11 objectives, and each of those are delineated here. We will be going through all of these objectives as part of this podcast. Now, this first slide, the uninsured. In 2013, there were about 42 million people in the U.S. who did not have health insurance. This has gone down some with the Affordable Care Act, also known as Obamacare. In the 19 to 25 age group, 22 or almost 23% are uninsured, down from 29% in 2008 and 31% in 2005. Only 7.1% of Americans with household income greater than $75,000 are uninsured. So you can see it really is dependent on income. About 28% of foreign-born residents are uninsured compared to 11% of native-born residents. Removing one of the financial barriers, being insured does not guarantee receiving quality of health care. Having insurance is not an independent predictor of getting preschool vaccinations. So although you may be insured, it doesn't guarantee receiving quality health care. That's one of the arguments against Obamacare. It insures people, but it doesn't guarantee receiving quality health care. Also looking at the uninsured, there's other barriers, system barriers. There's a lack of scheduling flexibility, long wait times. There's personal barriers, including reliable transportation, the home environment, employment conflict, and health education and misinformation. Early health insurance programs, when you're listing those out, there's the Marine Hospital Service, authorized in 1798, the Massachusetts Health Insurance Company of Boston, back in 1847 it was started, Plans offered for the gold rush workers in 1849. Early plans were more disability insurance covering specific diseases. Later, they were expanded to cover other diseases, but only reimbursed patients for out-of-pocket costs, income protection. Going on, hospital insurance historically. In 1929, Baylor University Hospital in Dallas offered hospital care Blue Cross to a group of teachers on a prepaid basis, $6 per year per person, if you can believe that. Well, inflation now. As insurance increased, financial barriers to hospital care and the demand for care increased. During the Great Depression, hospitals with empty beds and declining revenues were financially stabilized by such insurance plans. Patients were restricted to the hospital supplying the insurance until Blue Cross offered coverage statewide. Hospitals were not paid directly, and patients paid the hospital and then were reimbursed by the plan at 80% of the first 21 days of expenses. Looking historically at medical insurance, at about the same time, Blue Cross was instituted, a large medical group practice, a unique arrangement at the time. In Los Angeles, they started a plan to cover physician services. In 1939, the California Medical Association established the first Blue Shield to facilitate payment for medical service, which was reimbursed at a percentage. Because of wage and price controls during World War II, companies offered health insurance as a benefit, which was not covered by the controls to attract labor. In a short time, the population covered by health insurance increased from 5% to 50%, quite a jump. Major medical insurance, historically Blue Cross and Blue Shield, eventually merged, as did several other commercial insurance companies, to provide hospital and medical coverage, physician costs. By the 1950s, most employee health plans took the form of major medical insurance, which also offset expenses from catastrophic illness and injury. At the same time, the health insurance industry, reemphasized income replacement by offering long-term disability insurance policies. Now, indemnity versus service benefit insurance, you need to understand the distinction here. Indemnity insurance is reimbursement of a percentage of expenses to subscribers rather than direct payment to providers. The predominant form of health insurance for decades. So when I was in pharmacy school, indemnity insurance was probably the most predominant form of health insurance. That's changed because there were drawbacks. Patients had to save receipts, fill out forms, and it was expensive for insurance companies to process. Because of this and reimbursement on a retrospective fee-for-service basis, cost and premiums rapidly increased and companies had little ability to control it. Physicians essentially had a blank check at that time. Now providers are paid directly, which allows for cost controls, for example, standardization, automation, negotiation of discounts. Now, there are current insurance trends. Private insurance primarily is supported and reinforce existing patterns of health services. This neglected prevention, control of communicable diseases, and care for those not covered and with high incidence of disease became the responsibility of the public sector. This was addressed in 1965 with Medicare and Medicaid. As healthcare costs rapidly increased in the 1970s, employer groups and insurance companies desired to control reimbursement of providers and utilization of services. Until recently, quality and outcomes were not priorities. Looking at the evolution of prepaid prescription drug programs, until the early 1970s, most prescription drug coverage was only available through major medical insurance programs. Prescription drug coverage was a small percentage of the claims and therefore a low priority. A large number of small claims was not consistent with principles of insurance of risk management. Antitrust laws prevented pharmacists from negotiating prices as a group. As the demand grew for this benefit, a new industry arose to manage this service, PBMs, pharmacy benefit managers. Looking at the structure of the health insurance industry, the term third-party payer may suggest that there are only three parties involved, but the structure of the insurance industry is far more complicated. There are stakeholders, patients, employees, dependents, employers, unions, insurance companies, related industries, actuaries, underwriters, business products, etc. And then there's providers, physicians, hospitals, and the government, and also non-government organizations like accrediting agencies, universities, researchers, trade groups, and professional organizations. Looking specifically at these different kinds of stakeholders, there's actuarial analysis. It's a statistical analysis of the population served and an estimate of the necessary income to cover the estimated expenses. Actuarial analysis, there's estimates, it estimates three expenses. The cost of each type of service, utilization rates, administrative expenses, necessary to income to cover expenses is expressed as the cost per member per month. So there's a lot to be said for these actuarials, statisticians, and the insurance agencies, what they do. Continuing on, some, usually large corporations, self-insure rather than use an insurance company. Most states require a restricted escrow account that guarantees payment of health benefits. Most use an underwriter and may or may not have administrative services. So if you have enough money in a large corporation, you may not be working with a health insurance company. You may just do it yourself. Different principles of risk management. The purpose of insurance is to help individuals and businesses manage certain types of unanticipated risk. For example, premature death or serious injury. There's anticipated risks that are not insurable, like asset depreciation. Purchasing insurance requires a known small loss, a premium, or protection against a large unknown loss. For example, trading certainty for uncertainty. And insurance does not remove the risk of loss, but transfers part of the risk to the insurer. Moving on, there are two types of risk. There's pure risk and speculative risk. Pure risk involves the possibility of loss, but no gain. Examples are fire, storms. These pure types of risk are insurable. Speculative risk is chance of gain as well as loss. Examples are gaming and starting a new business. All these types of speculative risk are uninsurable. Now, from this particular slide, you will be having an IRAT, so you may want to make a note on your outline. Pure risk becomes insurable only if the probability of the event can be accurately determined. The event occurs irregularly on an individual basis. The loss is accidental. It results in a substantial loss. The loss is measurable, can be attributable to a specific event, and it's readily quantifiable in monetary terms. Finally, the individual must have an insurable interest, personally suffers the loss. So the IRAT involves knowing that accidents are insurable. You need to know on this particular slide from it that accidents are insurable. Prescription coverage. If a prescription coverage provides relatively small benefit at a high administrative cost and is inconsistent with some of the basic principles of insurance, why is it covered by health plans? Drug therapy can be preventative and mitigate and or delay the expenses of other more costly therapies. However, the potential benefits are not always realized. So health insurance will cover prescriptions because if you get your prescriptions, it usually will keep the other more expensive coverage at bay, those costs down. That's the reason why. On this next slide, you will get a IRAT from this slide, so be careful. You need to know about catastrophic hazard. Most policies do not cover catastrophes, events that if covered would exceed the company's ability to pay. For example, war and earthquakes. Many insurance policies, they call this an act of God, and it's not coverable. So if you have a war, your insurance will not cover, or like if your house is destroyed with a A-bomb or something. Companies limit their exposure by avoiding insurance. Large numbers of policy holders in the same geographic area. Adverse selection. If one knew when a loss would occur, individuals or companies would buy insurance just before the loss or drop it when it was no longer needed. This is adverse selection. Adverse selection raises premiums for future policy holders. So, for example, in a lot of health insurance policies, they won't allow a woman to get pregnancy insurance for pregnancy within a 9-month period, elimination period. Also, homeowners insurance, there's elimination period, so a person can't buy for our insurance, home insurance for hurricane damage, just like within a couple of days of a hurricane. So you need to know that individual insurance policies are more expensive than group insurance policies because individual insurance policies present greater opportunities for adverse selection. So again, this is an IRAT that's based on this bullet under adverse selection. Insurance for individuals is more expensive than group insurance policies because they present greater opportunities for adverse selection. Going on, potential risk management problems, incentives to create losses. A policyholder actually gains from a loss, insuring a car for more than it is worth. which incentivizes the loss. Supplier-induced demand, a person paid for a service, determines how often the service is provided. There could be a potential conflict of interest. And finally, again, we discussed this earlier, moral hazard. Decreasing the out-of-pocket losses increases the likelihood that the peril will occur. Having health insurance encourages patients to consume healthcare services of low value that they would not otherwise use. Overconsumption increases premiums for all. On this particular slide, there's an IRAT that comes from this slide. Group policies, they're less prone to adverse selection. It spreads the risk over a large population where most are healthy. There's an elimination or exclusionary period, decreases adverse selection by not covering pre-existing conditions for a certain period of time, like pregnancy for 9 months. Less expensive to sell and administer. It spreads administration costs over a larger population. Popular with employees because they do not have the tax liability they would have if they were given an increased salary to buy their own policy. Employers can deduct the benefit as an expense, which decreases their tax liability. So that bullet at the end is very important. People wonder why employers provide the health insurance. It's to decrease their tax liability and also get to have more healthy employees. So from this slide, you will have an IRAT. You need to know that the elimination period, that second bullet, is designed to control the problem of adverse selection. Moving on, coverage limitations. Even if a service is covered, there are limitations that may be placed on how much or how often it will be reimbursed. This allows insurance companies to avoid adverse selection and minimize costs. There's a coordination of benefits. Policies include a coordination of benefits provision for when a loss is covered by 2 or more insurance plans, so as to limit total reimbursement to the amount of loss. So, for example, sometimes retirees have Medicare when they're older, as well as the DOD's TRICARE for Life. So there's a coordination of benefits between Medicare and TRICARE for Life. Or Medicare and Medicaid is another coordination of benefits example. There's a subrogation provision that determines the order in which overlapping insurance plans will pay. So if you have 2 types of home insurance, there will be some kind of provision that maybe the first one will pay 80% and the second will pay the 20% left over. Now, again, on this next slide, there will be an IRAT, so be careful here. Pharmacy benefit managers, prescription drugs, are a high administrative cost benefit that requires huge volumes to be cost effective, hence the rise of pharmacy benefit managers. For the above reason, health plans usually carve out this benefit to be administered by a PBM. So even though you may have Blue Cross Blue Shield insurance, there may be a PBM working with Blue Cross Blue Shield to provide this insurance for your prescription drugs. There is a participating pharmacy agreement participating or network pharmacies contract to provide specific services for a specified reimbursement. If only a select number of pharmacies are allowed to contract, these pharmacies are known as preferred pharmacies or providers. So from this slide, I want you to know that a PBM, which is a pharmacy benefit manager, at least for this IRAT, a PBM is responsible for controlling costs in a prepaid prescription program. Moving on, when we were talking about the administration of prescription drug programs, there's elements of a participating pharmacy agreement. We will be talking a lot about this more in the pharmacy management course you'll be taking from me next year. You need to know that reimbursement is equal to a dispensing fee plus ingredient costs minus the patient cost sharing. It's based on three factors: the dispensing fee, which is a fixed amount for every prescription dispensed. The ingredient costs are based on the estimate of the cost of goods sold, and patient cost sharing. Maybe they have to pay a certain amount for each prescription. There's ingredient costs, and there's a lot of alphabet soup here. You need to know estimated acquisition costs, or the EAC, is usually based on a percent of the manufacturer's average wholesale price, which hopefully is higher than the actual acquisition cost paid by the pharmacy. Brands with generics may only be reimbursed at the cost of the generic, which is the maximum allowable cost, often called MAC. The difference between AWP and AAC is called the earned discount, which is a total of three other discounts, those being volume, cash, and trade. The difference between the reimbursement and the AAC is the gross margin, GM, or gross profit. Again, this is something we'll cover in much more detail next year when you take pharmacy management. Suffice to say, this is the a lot of this is discussed at pharmacy association meetings and trying to get pharmacists reimbursed for their services at a reasonable cost. Moving on, patient cost sharing. There are shifts. It shifts some of the costs of the plan to the patient. May have a stop loss, maximum out-of-pocket amount, after which the plan pays 100%. May also decrease utilization. There are three types of patient cost sharing: co-payment, deductible, and co-insurance. So when you have prescriptions and you're taking them to pharmacies, these shift some of the costs of the plan to you in the form of co-payments, deductibles, and co-insurance. Oftentimes you'll look at a person's insurance card, and it will have these payments that they have to make, like, I don't know, $10 for a generic and $20 for a brand is a common co-payment that you have to pay to get the prescription. Moving on, co-payment is a specified amount every time a service is received. Most common, may be tiered, different amount for different formulary categories: generic, preferred, non-preferred. So if you're looking at a drug, a brand name, the PBM may specify a preferred drug that they would rather that you get. Non-preferred, they just don't think it has the biggest bang for the buck. You can get it, of course, but at a higher price to their preferred that they specify. There's a deductible. A patient pays out of pocket up to a specified amount over a period of time, usually a year, before the plan kicks in. Co-insurance, patient pays a specified fixed percentage of a service, usually 20%. So, for example, surgery, you would pay 20%. The insurance company may pay 80%. Administration of prescription drug programs, there's the payment, total reimbursement. The plan and patient should cover the AAC, the COD, and the net profit. There's a break-even point, the BEP, which is equal to the AAC plus the COD, and the gross margin is equal to the reimbursement minus the AAC, which should be sufficient to cover COD plus NP. I know this is an alphabet soup. And again, we'll get into this much more in a detailed way next year with your pharmacy management class. But suffice to say, it is important each year, if you're reaching out to a PBM to sign a contract for filling prescriptions, you need to keep in mind these costs. Because if your cost exceeds your reimbursement, you may very well go out of business. So you do need to keep a handle on all these costs and make sure that you're going to be able to fill these prescriptions below the total reimbursement. Most plans, the total reimbursement for a prescription, however, will not exceed the pharmacy's usual and customary or UNC charge. Price paid most commonly by private pay patients. Therefore, most plans reimburse the lower of these. Some plans are shifting from paying EAC to wholesale acquisition cost rather than AWP set by the manufacturer. Public plans are considering using average manufacturer's price based on the actual cost of the manufacturer instead of the AWP. Finally, this last slide, the impact of the health insurance on the pharmacy. Since the mid-1990s, dispensing fees have declined, while inventory costs have increased. Since 1986, gross margins have decreased from 32% of sales to 23% of sales. Pharmacies that survived through increased efficiency, automation, and decreased expenses have been able to maintain a net profit around 3% of sales. Pharmacists need to control product costs and overhead. Using automation and technicians appropriately can lower costs. And that's the end of this slide and the end of this podcast. Thank you.